Good morning, everyone. Welcome to TeleShadowing. We are recording this session and live streaming it to YouTube. We will be having a Q&A session at the end, and you can ask questions in the YouTube Live and Zoom chats, and they will be addressed. I'm honored to introduce our mentor for today, Dr. Cheema. Dr. Cheema is an accomplished internist. She completed her internal medicine residency from the University of South Florida. She's a mentor to students and a published author in neuroendocrine tumors and infectious diseases. Dr. Cheema participates in community services and believes in health for all. She's also running a clinic for low-resource patients. I would now like to request Dr. Cheema to start today's session. Thank you.
Good morning, everyone. Thank you, Amna, for the introduction. I really appreciate it. Today, we are going to talk about internal medicine. I will talk briefly about my life story. Then we'll talk about the self-care. We discuss one simulated case as well, and one case study. And then at the end, few tips to success. So let's start today's session. So briefly about myself, I completed my internal medicine residency at University of South Florida in Tampa, Florida. And internal medicine is a 3-year program. And I had a quality life there. I had a great time of my life in Florida, along with my kids, who enjoyed the Disney World almost every other weekend. They used to go there while I was doing my residency. And after completing my residency, I started practicing as an internist, both inpatient and outpatient care. And currently I'm practicing in Maryland. I'm a mother of 3 kids, and my youngest one is making YouTube videos during this pandemic. And I would like to share her video with you for fun before we take a ride of internal medicine and talk about self-care and well-being. So let's see if we can play this video.
Hi everyone, my name is Nora and I'm 5 years old. Welcome to Nora's Talk Show. Today I'm going to talk about the MCAT. What is the MCAT? It stands for Medical College Admission Test. The MCAT has 7 subjects. Those subjects are behavioral sciences, biochemistry, biology, general chemistry, organic chemistry, physics and math, and the CAR section. CAR stands for Critical Analysis and Reasoning Skills. I'm going to show you the different books of Kaplan. Let's pick Behavioral Sciences first. This is the Behavioral Sciences Review. This is the Biochemistry Review book. This is the Biology Review book. This is the CARS book. This is the General Chemistry Review book. This is the Organic Chemistry Review book. This is the Physics and Math Review book. Now I showed you all 7 review books. We need to remember to work hard to earn a high score in the MCAT, so we can go in the medical school and become doctors and help others. One more thing. There is another store for MCAT review. It's called UWorld. UWorld is an online cube bank. We can practice MCAT questions. Practice makes perfect. See you next time.
All right, so I hope you enjoyed this video and a little bit about MCAT. All right, so before talking about the simulated case and the case study, let's talk about self-care, well-being. It's very important. You need to be compassionate with yourself. And why do we need self-care? Why we need to be compassionate with ourselves, right? To burn out, to achieve our goals in medicine or whatever field you want to choose. So medicine is a very challenging but very highly rewarding journey. And we need to pay attention to our well-being as well, and to understand ourselves. And there's a sense of well-being, there's international criteria that we need to ask these questions to make sure we are up to par and taking good care of ourselves as well. And as we are not only the custodian of our acts, we are custodian of our perceptions as well. And we should ask these questions to get a better idea of our well-being. So first of all, ask yourself, are you happy about your health? Do we have a good appetite? Do we enjoy comfortable sleep? Like when you wake up, are you fresh? Are you energetic? Do we perform workout daily? And now this emotional part, do we get angry very easily? Do we get upset if our opinion is rejected? And what do other people think about us? Do we get constant feedback, constructive feedback to improve ourselves? And are we growing? So there are different domains that I will talk about briefly. And are we sure about our purpose of life? So these are all the questions that we can ask ourselves to do self-analysis, to know better about ourselves and know why I'm alive today, right? There are many people who could not woke up this morning, and we all are blessed that we woke up, we are breathing, we are here together to learn as much as we can, and coin in your mind how I can make a difference to help yourself and help others. All right, so very briefly, I will go over the 4 domains of self-care first. So what is self and what is well-being? So self has 4 domains: physical health, mental health, emotional health, and spiritual health. This is all about our body, mind, heart, and our soul. So physical activity or physical health has 4 domains that we need to work on. We need to make sure we are doing exercise every day. Are we doing workout on a daily basis or not, or 3 to 4 times a week? Watch out your diet. Are we eating healthy? Add more fruits and vegetables in your diet. Make sure you're well hydrated. And about your sleep, do you have quality sleep? So maintain constant sleeping hours to make sure when you wake up in the morning, you're more energetic to take care of your day. And last but not least, your stress. How do you manage the stress? And stress is normal in our life, but main thing is we have to keep in mind how to manage it. To some extent, to meet our goals, to some level is good. But when it's pathological stress, it affects our body, it affects our well-being. So we have to keep an eye on all these to make sure we are taking care of our well-being. So this is self-acronym I made for myself. As self, as for sleep hygiene, E for exercise regularly, learn to manage stress, and F for food, take care of your diet. And next is emotional health. Emotional health concept was first given by Daniel Goleman. He has a very good book if you guys want to learn more about it. It's called EQ as well. And there are 4 skills we need to learn. It's about learn how to respond appropriately and not to react aggressively. So emotions are very contagious. And basically emotion is a state of mind associated with our thoughts, our feelings, and our behavioral responses. So emotional intelligence has 4 skills that we need to learn. And it's being said to get a job or get a position, you need IQ. But to keep your position and go a higher position, you need EQ. So you need to work, make sure your EQ level is high as well. You have a high EQ, emotional intelligence as well. So in this include self-awareness. You need to know about yourself. It's called self-actualization as well. Know your strengths, your weaknesses, your emotion, recognize yourself and see your weakness areas, how you can improve, and your strengths areas. You can further improve those strengths areas. And then social awareness. You also need to know about others' emotions, others' feelings, how they are going through. Put yourself in their shoes. So then you will be better understand other people as well and show the compassion for others. And what we can do, self-management, how we can do that. Again, self-management is a broad term. We can do the time management. It can be first of all, how to manage our anger, how to manage our habits, our behavior. So we have to keep an eye on all these to manage ourselves. And then most importantly, when you're dealing with other people, relationship management is very important. We need to learn, and when we have better understanding of others, have empathy for others, when we have a ability to understand and share others' feelings, so then we know better how to manage our relationship, because it's a big issue worldwide, how to manage our relations. So emotional health is very important as well, and it's a very important skill to learn. And so please make a habit to improve emotional health, and it will help you with your self-care. So next we have IQ. So IQ has 4 areas as well that we need to work on. It's all verbal intelligence. We can work on our communication skills. That's very important. And then our perception, our logical reasoning. So we can disagree with other people without being disagreeable. So we should be very good in communication skills, our leadership skills, where we can know how to manage the conflict, how to convey your point of view, and then working memory. So how we can improve working memory by practice. Everything is practice in this world, there's no magic. And then processing speed. So we can improve our IQ as well by practicing, by reading more books, by getting more knowledge, and by practicing, it will help us to improve our intelligence as well. Last but not least, thus our spiritual health means how we perceive what is the purpose of life, why we are here. So it's very important to see our spiritual health as well, our moral values, our ethics, what is the purpose of life. Of course, we can help ourselves, how we can help ourselves and how we can help others, how we can contribute, how we can pay back to the community. And then we all need to understand our social responsibility. And then attitude of gratitude. Always remember that we are blessed. We have a lot of blessings, count your blessings every day and be grateful about it. And people who are less blessed, try to help them, try to make their life easy as well, as much as you can at your level best. So this is all about spirituality. Just know your spiritual core and just ask yourself the meaning of life. It will help you to think more positively and be optimistic, and attitude of gratitude. All right, so this is all about lifestyle modifications. We are the creatures of habits. And there's a American College of Lifestyle Medicine. Is it a society of physicians and medical professionals dedicated to be focused on preventive healthcare and self-care. I'm also a member of ACLM, and there's very good resources we can learn from it as well. And I got this from Lifestyle Medicine, College of Lifestyle Medicine. Eat plants, keep moving, sleep well, be present, stay calm, and love people. I hope it will help you with your well-being as well. All right, so let's start with our simulated case. So this is a disclosure. So the information is just for educational purposes only for the students. And please remember, if you have any medical conditions, any emergencies, call your doctor or call 911 in case of any emergency to seek medical care. All right. So let's start our simulated case. When I took the USMLE, we had a clinical skills exam in which we were given simulated cases to diagnose. And I think there were 10 to 12 cases, and we were supposed to take history, do physical examination, and counsel the patient if needed. And after that, we diagnose and for those simulated cases and order diagnostic workup and make the treatment plan. These were all how the simulated cases were designed to assess our clinical skills. So that's the purpose of teleshadowing. That, of course, given pandemic, we have limited opportunities, So we want to make sure you are getting most out of it and use best you can learn from this. And as we mentioned in the previous session, that we will try to add simulated cases for better understanding. So you can get the most out of these learning sessions. And please feel free to ask questions. You can raise hands first, as there is an option on the Zoom, and you can ask questions one by one and make the best of use of your time to learn. And I will ask questions as well. And if anyone is interested, you can unmute and you can answer and make it more interactive. So we have a simulated patient, one of the TeleShadowing team member. She volunteered for this, and I appreciate her help. So let's start our case for today. And then you have to listen to this case very carefully. This is about our history taking, and we'll try to be slow so you can understand. And then if you have any questions, raise your hands, and we will ask the questions, and we will answer the questions, and we'll try to address your questions. All right, so let's start. We have a simulated patient here. All right. Hello, Ms. Hill. It's Dr. Cheema. How are you doing today?
I'm okay. How are you, Dr. Cheema?
I'm good. Thank you for asking. I really appreciate your patience. I was in my virtual waiting room. I was with a patient waiting for the one patient I was taking care who need urgent care.
Thank you for letting me know. I appreciate it.
All right. So how can I help you today, Ms. Hill?
I have a pain in my stomach area.
All right. Can you please tell more about it?
Yeah, it's been going on for about 1 or 2 months, about 2 months of off and on. And it's been a constant pain for the last 3 days.
Okay. All right. I'm sorry to know that. I need to ask you a few more questions to get better understand your pain so I can help you better. So you said you have pain for last 2 to 3 months, correct?
Right, that's correct.
All right. And for last 3 days, you have this constant pain?
Yes.
All right. So how can you locate this pain first in your stomach? Can you point out where's the pain?
Yeah, sure. It's over here in this area.
Okay. All right. Yeah, it's called epigastric area. Okay. All right. Got it. So how you will grade your pain is on 1 to 10 scale. 1 is less pain and 10 is worse pain.
I would say it's an 8 on the pain scale most of the time.
Okay. All right. And how does the pain feel like? It's like a sharp pain, achy, dull, burning sensation?
It's mostly a dull and achy pain.
Okay. Does this pain radiates towards your back or somewhere else in your stomach?
Yeah, it does radiate towards my back side a little bit.
Okay. All right. Does this pain is constant or comes and goes?
It comes and goes, but for the last 3 days, it's been constant.
Okay. All right. Any aggravating factors that make this pain worse?
Yeah, after eating food, it gets worse.
Okay. Any relieving factors, any palliation factors that make this pain better?
Yeah, I guess avoiding food helps me ease the pain.
Okay. All right. Are you taking any over-the-counter medicines to help you with this pain?
Yeah, I tried taking Tylenol, but it didn't really help much.
Okay. Do you have any associated symptoms along this pain, like any nausea, vomiting?
Yeah, I've been feeling some nausea for the last few days, and now I've just been vomiting for the last 2 days as well.
Oh, I'm sorry to know that. How many times did you throw up?
Yesterday it was, I think 3 times total.
Okay. What's the color of the vomitus?
It's all food particles with some liquid in it.
Okay. Did you take any medicine to help with the vomiting?
Yeah, I tried over-the-counter medicine for my nausea, but it didn't really help much either.
Okay. All right. Thank you. All right. So we will stop here, and I would like to ask you guys what you think, what's going on with the patient. So we took the history about the pain. Of course, after history, we go over the review system from head to toe. Then, of course, we do the exam from head to toe. But I would like to stop here, and I would like you to let me know what you guys think going on. Said by like differential diagnosis. So I will give you some time. You can think about it. Like I asked about the patient mentioned about the pain. And this is the epigastric pain. I will talk more about the different regions of the abdominal area, which one is the epigastric region, which organs come in that area. So you will have a better idea what I'm talking about. So when patient mentioned about the pain, so we ask about questions about the pain, like provocation, PQRST. This is the acronym we can use, like P for provocation, any palliation. I asked about the quality. I asked about any radiation. Patient mentioned pain goes towards the back. Then I asked about the severity. On a pain scale, I asked, patient mentioned it's 8 on scale, and then asked about the time, and I asked about it, like duration, onset. So this is, I asked about all these questions about the pain to get better idea about the pain, what's going on. So based on this history, what do you think is going on with the patient? You can raise your hand and you can answer, or you can unmute yourself. Let's see. Can I mute myself? All right, so someone type in the chat box appendicitis, and Amna is raising her hand. Okay, Amna, please go ahead. Let me know what do you think, what's going on with the patient?
My guess would be a stomach ulcer, maybe.
Stomach ulcer, okay. So do you know any terminology, what we call a stomach ulcer, or?
No, I don't.
Okay, that's okay. All right, let's see if any other responses we have. So patient mentioned epigastric pain. Let's see if anyone else want to answer or type in the chat box. Okay, right. So I saw the answers: indigestion. I'm guessing stomach ulcer, acid reflux, peptic ulcer. Okay, so we got few responses. And anyone interested to interact, you can unmute yourself to make the session more interactive. And you don't need to be shy, right? We all learning. This is the learning session. So there's no right and wrong answer. So please don't shy if you have any, you want to talk. So this is how, this is all about your communication skills. So I would encourage you to please answer and unmute yourself and answer yourself, to verbalize instead of typing, but it's okay. You can do that if you are not comfortable, but it's okay. We're trying to make it more interactive. Okay. One said hepatitis. Okay. All right. So we have few differential diagnoses. So just based on history, we make these differentials. And let's see. So after taking this history, we go review system from head to toe, and then we do the physical exam, and then we build up differential diagnosis. So yes, it can be peptic ulcer disease. It can be gastritis. It can be esophagitis, cholecystitis. It can be pancreatitis and hepatitis. So why I'm saying all these, right? So these are all I said: gastritis, cholecystitis, pancreatitis, hepatitis. All these organs are lying in this area, epigastric region. So I would like to go over these regions first, so you will have a better idea about the abdominal regions, about abdominal quadrants, and then we'll come back again on the differential diagnosis. We'll talk in more detail. So here it is. Let me close this chat box first. Okay, so there are 9 divisions of the abdomen, and we divide them in 9 quadrants by 2 vertical and 2 horizontal imaginary planes. And these 9 regions are named, and each regions have all the abdominal organs. And when someone tells us we have pain, we ask them, okay, the location, where it is. So when patient localize the pain, here's the pain, then we ask about the radiation. So we can see, okay, so this is how we think about and how we are building up this differential diagnosis, right? So someone said appendicitis as well. So I would tell more in detail why it's not appendicitis, why it's more towards the pancreatitis or peptic ulcer disease. So let's go over these quadrants. So these are 9 quadrants divided by 2 vertical and 2 horizontal imaginary planes. So this first region is called hypochondriac region. This is the epigastric region where our simulated patient pointed out the pain is here. Then left hypochondriac region, right lumbar, umbilical region, left lumbar, right iliac, hypogastric region, and left iliac. So these are all regions to help to know which organ is in which quadrant. So right hypochondriac has a liver, gallbladder, right kidney, and small intestine. Then epigastric region, there is a stomach, liver, part of the liver, part of the stomach, part of the pancreas, and adrenal glands, and part of the spleen as well, and duodenum. So these are all the regions. So when you were in medical school, and of course all the IMGs who already know that, they have gone through, and I'm just trying because we have high school students with us as well, undergrad. So I'm trying to go with the basics, and of course I will talk more about it so it can help everyone. And then hypochondriac region, we have a part of the spleen, we have colon, left kidney, and pancreas, part of the pancreas, not all of it. And then we have right lumbar region, again, part of the gallbladder, liver, right colon, then umbilical region. We have different organs here, parts of the small intestine. Then left lumbar region, we have descending colon and left kidney in this area. The right iliac, this right iliac region has appendix. So that's the reason one student mentioned appendicitis. So that's why it's less likely, but of course we cannot just rule out, okay, it's not epigastric region, we cannot, because again, sometimes it's referred pain, but it's less likely it's appendicitis. So in differential diagnosis means the first in the top you can think of. So so we can see appendix is in this right iliac region, and similarly patient is saying pain is here, right? So this is how appendix will be at our lower on the list. Then hypogastric region, we have a urinary bladder here, sigmoid colon, and the reproductive organs. Then left iliac, we have descending colon and the sigmoid colon. So these are all the regions I'm trying to let you know so you have a better idea why we're saying this is more likely, this is less likely. So now I would like to ask you, if someone is interested, to answer me. Of course, we mentioned there are 9 quadrants divided by 2 vertical and 2 horizontal planes. I'm going to ask you if someone can tell me what's the name of this abdominal quadrant. You guys can raise your hand. You can talk if you like. You can unmute yourself. You can tell your name first, and definitely you can tell me what's this region number 2 where I'm pointing. And I can give you a hint as well. The patient, our simulated patient, mentioned that she has pain in this area. So we talk about it. Let's see if someone is raising hand. Okay, so most are typing in the chat, epigastric region. Okay, good. All right. Epigastric, yeah, so we got 4 responses, epigastric. All right, okay, good. All right, so let's move on to our little bit more in detail, and then we'll come back and talk about all this. So this is I'm talking a little bit of anatomy and physiology, not much, just briefly. This is the liver, so this is the epigastric region. So before I showed you the quadrants, and now this is the epigastric region, right? Just below. So what epigastric means? Epi means above, the gastric means stomach, above the stomach. So this is the epigastric region, that part of the liver, part of the stomach, part of some esophagus, duodenum, part of the pancreas. So that's why we say this region epigastric pain, so we can think of. So these you can see all the major organs of the digestive tract. So this is the oral cavity. This is the esophagus, called food pipe, where when we take the food bolus, goes down, then go in the stomach, then all the gastric enzymes release to digest that food. Then it go in the small intestine, duodenum, jejunum, ileum. There's absorption of the nutrients there. And then this is a large intestine. This is called ascending colon. This is transverse colon. This is descending colon. This is sigmoid. And this is the anus. And you can see this small portion over here. You can see that behind the stomach, the pancreas. So it can be pancreatitis, right? I mentioned pancreatitis in differential diagnosis. Why I said so? because patient is mentioning pain for last 2 to 3 months, right? And of course, it can be gastritis, it can be peptic ulcer disease, it can be cholecystitis. So these are all organs there. So I'm trying to just giving you a brief overview of anatomy so you understand what's lying in this area, so we can broaden our differential diagnosis. And then next we can see over here, this is a little bit physiology. I will not go in detail. So this is the stomach inside lining. So this is the gastrin that release. And when there's a food in the stomach, it releases, stomach lining release the gastrin to help with the digestion of the food. Then this is the duodenum and produce a GIP. Then this is ileum, where is the mostly absorption of the nutrients. And this is the part of pancreas. So pancreas releases enzymes called amylase and lipase. So this is a brief physiology, what happens, how the digestive tract, digestion of the food and absorption. So absorption is mainly in the small intestine. All right, so next, this is again, these are the structure of the stomach wall. And this is when you go to medical school, when you do anatomy classes, you do the dissection. So this is how it looks like in the real. This is the liver, left lobe, right lobe. This pouch is the stomach. This is all the momentum. This is the diaphragm on the top. So I'm just showing a little bit of anatomy so you have a better idea what we're talking about. And so we have better understanding. All right, so let's move on. This is the blood supply I'm showing you over here of the all digestive tract. Not all, basically, just from the top. This is the, as I mentioned, ascending colon, transverse colon, descending colon, and this is the all the blood supply of the digestive tract. So basically, the gross anatomy and the regions of the large intestine and the little bit of blood supply as well. So over here, again, this is another view. This is the organization of mesenteries. What is a mesenteries? So mesenteries basically is a fold of the peritoneum. But what is peritoneum first? So the peritoneum is a serous membrane lining the cavity of the abdomen. And it's basically the covering of the abdominal organs, and which attaches the stomach and the small intestines, pancreas, spleen, and other organs to the posterior wall of the abdomen. And this is a diagram showing again all the digestive tract and all the part of the some mesentery as well. Okay, so I will just brief overview of the anatomy again. So liver, this is the left lobe of the liver. This is the right lobe of the liver. So this is the anterior surface. When we see from the outside, like if you're looking at me, you're seeing my anterior surface of the liver. And you will see this is the right lobe, left lobe. And when you see the posterior, you cannot see the posterior, you will take the liver out, and when you see read anatomy, you will see, so these are the lobes of left lobe, this is the caudate lobe, right lobe, and quadrate lobe. So these are lobes of the liver. And this is the transection anatomy of this. You can see the liver and all these organs. Just quick review of the anatomy. And this is the bile duct. This is the gallbladder sitting behind. It's a posterior part of the liver. If you take out the gallbladder is there. And then there's a hepatic portal vein, there's a hepatic artery, and there's a hepatic duct in there as well. And there's a bile duct. So this is a brief anatomy of liver, gallbladder, and ducts. And then this is the pancreas. It's lying behind the stomach. And it's basically the head of the pancreas is tucked into the C-shaped portion of the duodenum. Whereas you can see this is the C shape of the duodenum, and this is the head of the pancreas, body and tail of the pancreas. So the small portion of the pancreas lying in the epigastric region, and this is the diagram just showing you the histology. So in the medical school, we learn about the gross anatomy, and then we learn about the histology as well, how it looks like under the microscope. I will not go in detail. And this is again layers of the large intestine. And this is the microscopic picture Histology. And you will see different names, tinea coli, mental appendices, and all the histological, this is called columnar epithelium. I remember when I was in medical school, we were drawing all these with there was a called eosine, the hematoxylin. There were two different colored pencils that we were drawing, and these are all our lab part. But we were doing was look under the microscope, and then we draw these pictures, and it was really fun. And I still remember how it looked like. And of course, it's too much work, but this is how we learn, and gross anatomy, histology, microscopic view, everything. And it's how it's stuck in your hippocampus, and it stays with you. And every time you need to review, you just open and everything comes back in your mind. Oh yeah, you read it, and you draw yourself. Anyways, so let's move on. So we talk about this simulated case, and we'll come back again. But I'm gonna share with you one case study. And let's see, and then I will ask you about what is Okay, so someone raised the hand, and let's see who wants to ask the question. Let me go back. Okay, yes, Mohammed, go ahead. You can unmute yourself and ask the question. You have any question?
Yeah, I had a question. If it was esophagitis, wouldn't the patient also have chest pain?
Hello?
Yeah, my question was, if it was esophagitis, wouldn't the patient also have chest pain?
Yes. Good, it can be. So you're right. It's chest pain. Basically, I will more talk in detail about chest pain, and then I will correlate the epigastric pain and the chest pain. And in females, the epigastric pain can be because of the heart issues. It can be because of that myocardial infarction, coronary artery disease, because females have very atypical symptoms of coronary artery disease and myocardial infarction. So we cannot just say, okay, epigastric pain in female, but I'm just focusing on our simulated case because she is young. So because you are right, that chest pain is not esophagitis only. Epigastric pain, I didn't mention about the heart because it will make more confusing, but of course, at one other simulated cases, I will make both cases back to back, so you will be able to differentiate. The patient came with epigastric pain. So it's a digestive tract or it's a heart pain. So what would you do that, right? It's all the detailed history, past medical history, age, risk factors, causes. And of course, in the young patient, we should not rule out, we should not overlook, okay, no, it cannot be heart pain, but yes, you're right. Today, I was just focusing on the digestive tract because in the previous session, I talked about our MI and coronary artery disease. And yes, you are right that esophagitis pain is called sternal pain. Patients say, I have pain here. So this pain can be other sternal pain behind the sternum. We have a bone called sternum. So it can be esophagitis. It can be GERD. It can be gastritis. It can be myocardial infarction. It can be pleuritis. It can be pericarditis. So there's a broad differential, but it will be off the case. So I'm just focusing on one case. So you can learn more about this anatomy, physiology, and say, okay, this is the epigastric region. And then at one point in my next sessions, I will correlate the epigastric pain. So don't ignore the heart as well, because it's called referred pain come in as I mentioned in the females, atypical chest pain. And we should not ignore epigastric pain. We should not ignore cannot ignore and have to do workup for the myocardial infarction as well. Anyone comes with the epigastric pain. Did it help you, Mohammed? All right.
Yes, thank you very much.
You're welcome. All right, so let's go over another case study. And I'm gonna go over and you will tell me what's the diagnosis. So this is a 65-year-old female with a history of peripheral vascular disease and a recurrent chest pain. And patient underwent cardiac catheterization. So this will relate a little bit, but of course, so this is very tricky. That's the thing. So that's how you get, when you get training in your telemedicine, you learn, okay, how to differentiate. Is it the digestive tract at focus, or what my differentiation should go towards the heart pain, as Muhammad Ali mentioned about that. What about esophagitis? Chest pain can be heart. Yes, it can be. So let's go over this case pretty quick. So 65-year female with history of peripheral vascular disease and recurrent chest pain underwent cardiac catheterization 6 hours ago. So cardiac catheterization is a procedure that we do the cardiologists take care of it. Interventional cardiologist does that procedure, in which they put the if there is any blockage in the coronary arteries, they put the stent in there. First of all, they do the diagnostic and they find any blockage, they open up and they put the stent in there. So angiography showed 80% occlusion of the left main coronary artery, and the patient now complains of diarrhea. And so this means there was a occlusion there, and the patient had a procedure done. So this is how you have to make sure this all questions you will have in your board exams, in your USMLE exam, clinical exams. They give you clinical scenarios and they ask you diagnosis. Sometimes they ask you what's the next best step. Sometimes they ask you the management steps. So I'm gonna go over this. So patient now complains of diarrhea. So they give you a little bit of history. Patient had peripheral vascular disease, patient had this procedure done, and now patient complains of diarrhea and severe constant mid-abdominal pain. And they mention a little bit of examination. Patient has temp of 37.2, blood pressure a little bit higher side, 170/90. Patient is a little bit tachy, means tachycardia, pulse is 102, the respiration rate is 22. This means patient heart rate, patient is a little bit tachypneic as well, means respiration rate is on the little bit higher side. On examination, lungs are clear to auscultation. Abdominal exam is soft without any focal tenderness. And now bowel sounds are hypoactive, and there's no masses palpated, and rectal examination reveals occult blood in the stool. So which of the following is the most likely diagnosis? So keeping in mind, so of course, as we are talking more about the digestive tract disorders. So A is a gastric ulcer, B, perforated duodenal ulcer, is not duodenated, it's duodenal. And then gastroenteritis, mesenteric ischemia, and pancreatitis. So what do you think? What's a diagnosis? So let's see how many. Okay, in the chat box, if someone wants to say loud, you are more than welcome. You can unmute, introduce yourself first. Excuse me. Okay, two answers I got B. One is saying E, pancreatitis. Someone is saying duodenal ulcer. Let's see. Okay, so we got 3 responses. And in this case, we have to think outside the box. Okay, we get one more response. Let's see, C, gastroenteritis. Okay, all right. So these are all the possibilities, right? So now in this scenario, how we have to differentiate why it is this, why it is not this, right? So we have to keep in mind, patient had procedure done, and after the procedure, there is a chances of clots. Okay, any foreign body goes in the body, makes more clots in the body, and the patient had the diarrhea. So which symptom? Abdominal pain. Okay, yes, it can be gastroenteritis, but gastroenteritis, why they're giving us the history, the patient had a procedure done. So that it will rule out a gastroenteritis part. And for duodenal ulcer, they didn't mention about any nausea, vomiting symptoms, because duodenum is more upper GI part, but it can be possible, but it's less likely in this case. So the reason they gave us the procedure, because they make the clot. So what do you think if there's any clot, where it can go and make some disorders in the digestive tract? So answer in this case is mesenteric ischemia. So this is D. Why it is so? So what happened after the procedure, patient had some clots that went to the mesenteric vessels and caused a blockage there. So when there's a blockage, so as we talk about mesentery is, I'm going to go back again. What is mesentery, right? We just talk about it is a fold of peritoneum. is a serous membrane, but there's a mesenteric vessel I showed you as well. So there's a clot in the mesenteric vessels that cause the blockage. And when there's ischemia happens, so there was ischemia means there's a lack of blood supply, lack of oxygen that causes ischemia of that portion and causing this mesenteric ischemia. So diagnosis in this case is mesenteric ischemia. And I will show you the other anatomy and anatomy, how it looks like, the gastric ulcer, how it looks like. This is the gastric ulcer. This is you can see over here. So what is gastric ulcer? It's a sore that develops on the lining of the esophagus, stomach, or duodenum. So it's small intestine. And ulcers can occur when the stomach acid damages the lining of the digestive tract. And common causes include any bacteria can cause it, like H. pylori, any anti-inflammatory, like over-the-counter medication like ibuprofen, Aleve, NSAIDs, aspirin. So these are all the medications that can affect the lining of the stomach and cause sore and cause ulcers. And these are the gastric ulcer picture that shows under the endoscopy. So when patient has a long history, it's not because we give the medical treatment first, if the patient not responding to it, and then we do the endoscopy as a diagnostic and therapeutic. So this is how it looks like, ulceration. You can see over here in the mucosal lining of the stomach, you can see over here, this over here, this one is here. So these are all the endoscopic appearance of the gastric ulcer. Then there was a duodenal perforation of the ulcer. What does that mean? It means that you can see over here, this diagram. So there's a bleeding. When there's an ulcer and there's staying there for long and continuous irritation of that area causes the perforation, leads to bleeding. And this is a really emergency that we need an endoscopy right away and stop the bleed. And it comes under the GI bleed as well. So one of the cause is a perforated ulcer. And this is how it looks like under the endoscopic appearance. And then, as I mentioned, that endoscopy is a diagnostic and therapeutic. So first to diagnose where is this ulcer, so they find a location and then they cauterize, and then different procedures, different ways we can apply, we can do to stop this bleeding. And next we had then the differential diagnosis was gastroenteritis. So for gastroenteritis, in other words, we can talk about food poisoning, right? So in this, there's all inflammation of the stomach lining, all the small intestine, large intestine, and there's some viral gastroenteritis. Sometimes bacteria can cause as well gastroenteritis. So in this case, there's less nausea, vomiting. So they mention about the procedure specifically, so we can think of, okay, so this is the mesenteric ischemia going on in this patient. But of course, we have to, all these differential, we have to say why it's not gastroenteritis, why it's mesenteric ischemia. That's how this clinical scenarios. So this is how we have to manage every patient on person to person. We cannot just generalize, okay, this is the diarrhea and this, no, we are just focusing on diarrhea, but we are missing the other part the patient had 6 hours ago, why they're giving that history, right? So we have to think out of the box and think what other possibilities and make sure we are not missing anything in patient care. So these are the mesentries. I'm going to talk about briefly again because we make, as I mentioned, this is the mesenteric ischemia is basically the arterial occlusion and with ischemia, and is a complication of the angiographic procedure. So that's the reason they give the procedure up in the history. And this is the typical case of the iatrogenic occlusion. So the patient had the procedure done, and this patient is more susceptible to this complication because patient has a history of peripheral vascular disease, and patient has a history of coronary artery disease as well, right? So patient has already this history, and patient underwent the procedure, and this means patient has severe atherosclerosis disease. And this iatrogenic mesenteric ischemia occurs most commonly after any angiographic procedures or operations on the aorta. Aorta is a large blood vessel, and angiography may cause intestinal ischemia by dislodging the atheroma from a diseased vessel wall. Like patient already had diseased vessels, and when they put the instrument in the blood vessel, sometimes they put the instrument to the groin area, sometimes to the right wrist from the radial artery. So then they go in there, if blood vessel is already diseased, so they can dislodge that clot and that clot can go anywhere and cause the blockage of the blood vessel and cause ischemia. So in this case, then dislodging the atheroma from any disease vessel wall, and by the dissection of the vessel itself, or by the formation of the intimal flap. What does it mean? That it can cause the injury to the vessel wall from inside. So mesenteric ischemia is accompanied by the sudden severe epigastric mid-abdominal pain. There's a forceful vomiting, and there is a evacuation of the stool, commonly followed by the onset of the pain. And after the early after embolization, and after we do the physical exam of the abdomen. Patient it may be unremarkable in the first few hours. Exam will be unremarkable, like in this case. And later, patient can have a classic presentation of severe abdominal pain, and out of prolonged ischemia, it can cause tenderness in abdomen, like tenderness when you palpate the belly. Patient says patient has pain. And patient also can have an exam finding abdominal distension. It can cause guarding, and then there's a hypoactive bowel sound. What does that mean? It means that the bowel sounds were absent, or it was not that normal bowel sounds. They were hypoactive. These are all associated with intestinal infarction, and it implies a disease progression. And stool may be positive for occult blood, and there's no lab test or diagnostic for mesenteric ischemia, mesenteric embolism, or any visceral ischemia, but we can do some imaging tests to help us to diagnose this mesenteric ischemia. And also, as mentioned, that for gastric ulcer, there was mentioned that it can be gastric ulcer, but it will not occur suddenly, right? So all of a sudden, patient had diarrhea, all of a sudden patient had pain. Patient, like in our simulated case, patient is mentioning patient has pain for last 2 to 3 months, right? So gastric ulcer doesn't develop in few hours. So we have to think, okay, it cannot be gastric ulcer. This is how we will rule out, okay, not this diagnosis, this is the diagnosis. And then of course, patient, in addition, patient had a perforated gastric ulcer, excuse me. Patient would have some signs of peritonitis. Peritonitis means if there is perforation of a gastric ulcer or duodenal ulcer, there's some leakage of the gastric contents in the abdominal cavity, can cause peritonitis. Peritonitis means inflammation of the peritoneum. Peritoneum is the lining that covering all the abdominal organs. And this is how we'll rule out. And of course, pancreatitis. In this, the case study is not a pancreatitis. Why it is so? Because pancreatitis is less likely after cardiac catheterization. And of course, it can occur after the ERCP. If they given the history, the patient had the ERCP. ERCP sometimes done with the dye injection can cause it. Sometimes they do for the gallstone removal. So if they mention about that procedure, they can think of, okay, it can be pancreatitis. Sometimes they mention pain referred to the back, like in our simulated case, right? Patient mentioned that pain refers to the back. So I'm going to come back to my simulated case as well when we talk about the pancreatitis. So that's why I'm saying, okay, it's not pancreatitis. So we say, okay, it's more leaning towards the mesenteric ischemia. All right. And let's see. And also for gastroenteritis, why we said it's not gastroenteritis, because gastroenteritis or food poisoning occur in 3 to 6 hours after ingestion of any contaminated food. But patient didn't, there's no history mentioned in there, right? That patient eat anything. He was under the procedure. So this is how we'll differentiate. Okay, so next we have, so this we say this is most likely mesenteric ischemia in this case. And these are all the blood vessels. You can see over here, I'm going to show this is the main aorta, abdominal aorta. And this is all blood vessels. Mesenteric now supplying all the, this is colon, ascending colon, transverse colon, descending colon. And this portion over here, you can see ischemia. This is the area of ischemia, right? This is all you can see pinkish. This is a little bit grayish. The reason they showed it in this diagram because of the cut down of the blood supply in this area. That's why, because as I mentioned, it's a decrease of blocked blood flow to the large or small intestines due to buildup of the plaque, which is the basically hard waxy substance made up of the fat, cholesterol, and calcium in the arteries that cause the blockage. And another cause is the blood clots, which cut off the blood supply to the mesenteric arteries. All right. So how we do the diagnostic workup for the mesenteric ischemia. So these are all the imaging tests we can do to diagnose it. There's an arterial Doppler ultrasound. Basically, we can see the pictures over here. There's an ultrasound, and there's an option of there, we can do a Doppler, in which you can see, this is a Doppler studies, means we can put these are colors that show us the blood vessels. And basically, ultrasound imaging is a test that uses the sound waves to produce detailed images of the blood vessels and other structures in the body as well. And this test is used to measure the blood flow and identify any blockage in the blood vessels. And the ultrasound is painless, and it may be completed in 30 to 60 minutes. So it's very quick, we can get a diagnosis. And other test is the MRA. And MRA is basically the type of the MRI, and it's called magnetic resonance angiogram. This test uses a contrast agent. You can see over here, these are all the contrast that injects and that tell us, is there any blockage in the vessels, blood vessels, in the arteries that lead to the intestine. And in this test, a magnetic field and radio waves create this image. And then we can diagnose with a CT scan as well. You can see this dark area over here, right? And then angiogram. So this over here, you can see angiogram is again, we use the dye. You can see the white, so all the dye in the blood vessel. But over here, this circle, you can see there's no dye in there. So this means there's some blockage there. So this is how we can diagnose mesenteric ischemia, by doing different imaging modalities. All right. So next, I'm going to come back our simulated case. So this patient mentioned, our simulated patient mentioned, she has pain going on. And so after this, I mentioned review system head to toe. I will do exam on her. And since patient is at the urgent care, so I would like to do run some tests. And first of all, this was case of the pancreatitis, because patient mentioned for last 2 to 3 months, and also patient off and on. Now food makes it worse. Why food makes it worse? Because when we ingest the food, there's a pancreatic enzymes, amylase and lipase, release to help with the digestion of the food. So this is the one clue that patient mentioned, that whenever she takes food, it get worse. It eases up when she avoid the food. And so I'm more leaning towards a patient has a pancreatitis. So I'm going to go over briefly about the anatomy again. This is the
It's
liver.
11 o'clock.
Liver, the stomach, this is the duodenum, and you can see in the C-shaped area here, this is the pancreas, this is the head, body, and the tail. These are 3 different parts of the pancreas, and this is the pancreatic ducts over here that release the enzymes. And this is stomach area. This is the healthy pancreas. This is the inflamed pancreas. So inflammation of the pancreas is called pancreatitis. And what are the causes of pancreatitis? It can be gallstones, most common cause. And then patient give history of alcoholism. So that means we have to ask the patient about the history of patient is drinking alcohol or not. Then certain medications can cause it. So that's why I was asking the patient, is patient taking any medications? So the patient brought up with a Tylenol. And then certain medications that can cause pancreatitis are some antibiotics like tetracycline can cause it, some sulfonamide can cause it, valproic acid can cause it, some hormone replacement therapy can cause pancreatitis, and so on. And the high triglyceride level in the blood can cause. So when we have all these causes of pancreatitis in our mind, so we will order a diagnostic workup based on these to rule out these causes and figure out why patient has a pancreatitis. And then high calcium levels in the blood, hypercalcemia can cause it. And any pancreatic cancer is one of the cause of the pancreatitis. And then after any abdominal surgery can cause it, cystic fibrosis, and any infection. So these are all the common causes of pancreatitis. And based on these, we say, okay, now we have to rule out, we have to do further diagnostic workup to find the cause. Because, so we will confirm, basically clinically, we take the history, then we do a physical examination, and we do the blood tests. We do the basic test, CBC, CMP, we do the amylase lipase, the pancreatic enzymes, and then we do imaging as well. And we can do stool tests as well. We can do ultrasound. We can do CT scan. We can do MRCP. So these are all the diagnostic workup we can order for diagnostic workup for the pancreatitis. So this is the CT scan that's showing the pancreatitis. You can see over here. This is edematous. And this is the pancreas. You can see some dark areas over here. So this CT scan, we can say, okay, patient has a pancreatitis. So I will, since in this case, patient mentioned she has nausea, vomiting, and she said pain constant for last 2 to 3 days, and she has a 8 on scale. And so patient need to be, so now it's a patient came to urgent care, right? So now I saw this patient in urgent care. So now I have to decide, okay, I will treat and send patient to the home, or patient need inpatient care. So what do you think? In this scenario, I'm saying this similarity patient has a pancreatitis. So what do you think? Patient need inpatient care or patient can be treated as an outpatient? You can type in, you can unmute yourself, you can talk.
Sorry, can you repeat the question again?
Yeah, so my question is, for the simulated case we talk about, patient mentioned, so I can tell again, patient is a 35-year female, came in with the epigastric pain for last 2 to 3 months, off and on, intermittent pain. And now patient has pain, constant pain for last 3 days. Patient states pain is 8 on scale, dull, achy pain. Sometimes can be sharp, pain radiating towards the back. So, and aggravating factors, it gets worse with the food, ease up with when she avoids any food. She has associated symptoms of nausea and vomiting, and she's throwing up since yesterday. So in this scenario, then we did a blood workup, we did imaging, and the imaging, yes, I want to mention in the blood test, patient has elevated lipase. Lipase is a pancreatic enzyme. It's 3 times higher than normal. So patient has elevated lipase. We did CT scan. Patient has edematous pancreas. So what do you think in the management? Patient need inpatient care, or we can manage as an outpatient? Inpatient care means patient need more care that cannot be managed as an outpatient. In my previous session, I was talking about difference between inpatient care and outpatient care. So basically, this patient needs hospital care, or we can give some medicine and send this patient home. So let's see. There's no wrong and right answer. This is a learning session. Please feel free to answer. Make it more interactive. Let's see. Inpatient care, inpatient, okay. Inpatient, okay. All right. So mostly you're saying inpatient care. Why are you saying inpatient? Now I need to answer. Why you say inpatient? Why not? Why not give her some medicine, send her home? Now I'm asking another question, right? Can someone answer? Someone raise the hand. Let's see. Okay, that's really good. I will really appreciate you raise your hand, unmute yourself. But first of all, please introduce yourself and please briefly where you go to school, all this. So it will encourage others as well. We want to make it more interactive. And in future, we're trying to bring more similarity cases. And please be prepared for it. Ask questions. This is how we learn. And there's no right and wrong answers. So hold a second. Let me who raised the hand? Let me see.
Hi, my name is Nisha. I'm a fourth year student at Drexel University. I'm studying biology, neuroscience, and STEM education. I think it would be inpatient just because the patient had come in and was saying that she was complaining of this pain for 2 to 3 months and tried over-the-counter medications like Tylenol. So obviously we'll do some pain management, like whatever, but I think there just needs to be continued like screening or like just checking her blood levels and so on, just to see if like inpatient medication would help with what's going on. I don't know if I'm right, but
good. What Nisha, thank you. I really appreciate. I really appreciate. And you're right. So, you're right. And I will add on something. That's the reason first of all, Nisha, thank you so much for participation. I really appreciate it. Nishat is right. First of all, we need to manage pain, right? Yeah, if I give the patient some pain medicine and say, okay, go home, take pain medicine, it will get better. No, the main reason I need to admit patient has a nausea and vomiting. Patient cannot keep anything down. Patient cannot take orally, right? If I give her the pill, she will throw up, right? So patient need IV medication. We need to manage her nausea and vomiting. We need to patient NPO. NPO means nothing per oral. The treatment of pancreatitis, first of all, we have to diagnose, we see, okay, I mentioned that most common cause is a gallstone. So we did the ultrasound, we couldn't find any gallstone. So this means gallstone is ruled out. Patient mentioned patient does not drink alcohol. Okay, it's not alcohol cause, right? We check the maybe some hypertriglyceridemia. We check all the blood workup. So initially we just do the basic test, lipase was high, symptoms. So all these workup, patient admitted to the hospital, we do all the workup. We check for calcium, hyper and triglyceride levels, maybe that's causing it. And then we have to manage the patient. So in this case, I would, to be on the safe side, given nausea and vomiting, excuse me, patient is unable to take anything orally, right? Patient is saying, she threw up 3 times yesterday. If I'll send her with oral medication, patient will throw up again, right? So Nishat was right. With pain management, pain control, and also most importantly, nausea and vomiting, right? And the most important, we need to keep patient NPO. NPO means nothing per oral. So patient will not taking orally, patient will be dehydrated, right? So what we have to do, we have to give some IV medication. We make sure patient's getting IV fluids. So this is we can do in the hospital setting. So that's the reason we have to admit the patient. And of course, we monitor, as Nishad mentioned as well, monitor the vitals, make sure patient is the levels we can check again in 2-3 days, and we will keep monitoring patient vitals and patient is stable. Because what will happen if patient send the patient home and patient unable to take medicine, and so patient cannot, this patient should be admitted to the hospital. So these are the reasons: pain management, make the sure patient is not dehydrated because patient throwing up, right? So, and for last, she mentioned 3 episodes yesterday, for last 3 days. So we have to manage nausea, vomiting, we have to manage pain. And we have, so when we give the rest to the stomach, why we are keeping patient NPO? Because we have to give rest to the stomach, rest to the pancreas, sorry. Why? Because when we eat food, I mentioned that pancreas release the enzymes to digest the food, right? So this is how patient is not eating now. So there's no food in the stomach, it will be rested. So there will be no release of enzymes from the pancreas. I show you that in the anatomy, there's a pancreatic duct that releases the hormones. So patient will be at rest. So it will help with the inflammation. So that's how patient gets, we'll monitor every day. We'll see clinically how patient is doing. Based on that, we'll plan next steps, when patient can go home, and when patient start, then we start when patient's nausea and vomiting is better controlled, what we do, we start adding the diet slowly. And we see how patient is tolerating. If patient is tolerating, we go slow with the diet. We start with the liquid, then full liquids, then soft diet, then say, okay, patient is tolerating oral diet. This means patient can go on the oral medicine at home. And then patient need close follow with the primary care doctor, and make sure patient has routine follow-ups. And this is the case of the acute pancreatitis. And this is how we manage the patient, but of course it's all clinical judgment. That's why when we do training, it's very extensive training. This is how we judge. It's all clinical assessment and clinical judgment. How we, okay, this is pancreatitis, this is gastroenteritis, and this patient need to be admitted to the hospital. This patient can be managed as an outpatient, and this is how which tests we need to order. So this is all the workup, diagnostic plan. So this is how we manage this patient for acute pancreatitis. So we discussed 2 cases, mesenteric ischemia in elderly patient. We had the procedure done, right? And then we talk about pancreatitis. So again, if you have any interest in some cases that you really want to see, more outpatient cases or inpatient cases or geriatric population cases, so we'll try to add on more simulated cases, excuse me. We'll add from all the systems, so we can go over the anatomy, physiology, review. It will help for the high school students as well. It will help undergrad students, and I really appreciate our participant today, Nishat. So I will encourage you to please participate, to communicate. So the other mentors will come, and I will really encourage you to ask the questions. And we are giving opportunity to ask questions yourself. And please turn on the camera with other mentors. And so this is how they can remember you, to help you with your, if you're really good, they can remember you, they can help you with your letter recommendations. So this is how you have to make and do to networking as well, right? So I really want to make best out of this program, not just see 1 hour session and do the quiz and okay, you got a certificate. No, are you learning something, right? That's the goal. You should, are you really making best out of your time? So you woke up this weekend, or why you want, so again, ask yourself why I'm doing it, right? So again, as if you're doing it, and is it benefiting you? If it's worth of your time? So that's the real purpose of doing all this, and make it more interactive, get you involved, and I'm encouraging you, you all should participate. All right, so last but not least, keys to success. So again, be proactive is very important, is very plan ahead. and always, prioritize your time. Again, as mentioned in the self-management, first things come first. There's a very good book I can recommend. Again, I recommended in my previous session as well, 7 Habits of Highly Effective People. Is very important, prioritize. And then, of course, perseverance. So whatever your goal in your mind, stick to it, keep doing it, take small steps. If you have to go to the mountain, you take small steps. You cannot just jump and go at the peak, right? So you take small steps, and like ants take small steps, and by the end of the day, it becomes a big step like elephant. So start taking small steps and be perseverance and practice. Everything is practice in this world. And if you're really passionate about it, you will get it. I'm telling you, I can tell from my own experience, whatever you're doing, whatever you want to achieve, stick to it. Whatever you have dream about, so stay focused, be passionate about it, and never give up. And at the end, when you are so persistent and perseverance, putting all your efforts, and so all the nature start working with you. It's called law of attraction. I'm too much in psychology as well, because when I see my patients, they really need help, because sometimes our psychological symptoms present as physical symptoms. So that's why I'm very much in the learning psychology as well. So that's why I talk about a little bit in the beginning about well-being care, your self-care, and it's very important. And when you will achieve your goals, you will be at the position you find the purpose of life. Help yourself, help others, right? That's a goal. And you will feel so good. And then, of course, as I always mention, one candle lit another candle. At some point, you will be sitting where I'm right now, and you will be teaching others. You will be motivating others, inspiring others. And of course, do some volunteer work. And of course, these days we are limited opportunities, but that's why we're trying to make it more interactive. If you have any suggestions, please email us. And if you have any questions, I can share my email as well with you. You can contact me, but of course, I can share one thing that most students asking for letter recommendations. So we added in our website that for only dedicated and motivated students will get it from the letter recommendation from our mentors. You need to ask questions, you need to communicate, right? So if you're doing these you're doing shadowing or observership in person, you will be going all day from 9 to 5, or you will be there for long hours. So this is the opportunity that you are there for an hour and a half asking questions. We are giving you opportunity to ask questions so mentors can know you. So then after looking at your dedication, you're more persistent, you're attending regularly, you're doing live, taking your time, you're prioritizing your time. So it will show us, okay, so then after that process, the mentors, different mentors, they will take interview, they will check your skills and your knowledge, and then most of us are willing to provide the letter recommendation as well. But again, it should be, we need a more dedication. It's not just one session you guys attended and okay, you need that recommendation. I don't think so. It's worth, if I am the student, if I will ask, I don't think so anyone can do that. And I remember I volunteered for a year and I was there from 9 to 5. So then I got one letter recommendation after doing 1 year. Okay. So just keep in mind, nothing is impossible in this world, but of course you have to be very dedicated, prioritize your work. And I can share my email with you as well. You can send me email. If you have any questions, of course, it's better, send the email to TeleShadowing team. They can convey me, and we are more than happy to help. And other physicians sessions, whenever we had Dr. Quzada from University of Maryland School of Medicine. She was School of Dean, Associate Dean. So I will encourage, we asked the students to ask her questions directly, and she was replying them with their names. So this is how she can remember, right? So this is how you have to make connections with the mentors, and this is how you will get letter recommendations if you need. And of course, you will learn. And if you really want to be passionate about medicine, and of course, we are planning to add, if some students are interested in dentistry, some students are interested in a PA program, some are interested in some other programs, RN programs. So we are trying to find mentors so you can listen to their stories, get inspiration, learn how they did. And one more thing, everyone faces the challenges in the life. Everyone you have to do sacrifices. There's nothing free in this world. So you have to, no one will put in the plate and say, okay, this you can, the medics, no, you have to put efforts as well. And I'm sure you can do it. If I can do it, you can do it too. Okay. Believe in yourself and have purpose of life. And of course, take good care of yourself as well, your well-being every day, even 5 minutes, 10 minutes, do exercise, do some meditation, do some your rituals, your well-being, your thought process, be positive, all the weaknesses, improve your weak areas. So be a well-rounded person. Of course, we all do mistakes, right? We are human beings, but it's okay. Main thing is learn from your mistakes and move on. And that's the goal. All right, so I will be open to any questions, and I will have quick questions.
Thank you, Dr. Cheema. As we understand that you are on call, we will not be holding a Q&A session at this time. We welcome our students to email Dr. Cheema or TeleShadowing as we provided our emails. We truly appreciate you taking the time to answer our questions, Dr. Cheema. This was a greatly informative learning session for all of us, and I'd love everyone to please give a warm thank you to Dr. Cheema in the chat box for this incredibly informative session.
Thank you so much, Dr. Cheema. Now we're going to conduct our closing session with our quiz and future dates. So the link to the quiz for the session is now live, and you'll need a 70% or higher to pass and receive certification. And the link was just sent in the chat. And don't forget to also join our mailing list if you haven't already, as we send session and quiz reminders right to your mailbox. And you can join from the link that's being sent in the chat right now. And now we're going to move on to our next session dates. And these dates will also be posted throughout our social media outlets, so be sure to follow us at TeleShadowing. I'm looking forward to seeing you all at our next session, which is next Saturday on October 9th at 10 a.m. Eastern Standard Time with our physician mentoring us in neonatology. Thank you so much, everyone, for attending today's session, and we hope to see you in upcoming sessions as well. This concludes this week's shadowing.